Hi everyone, welcome to another Choices for Care training. This training is focused on adult family care without Choices for Care case management. As you are aware, as of July 1st, 2015, individuals who choose to live in an AFC home will no longer have access to Choices for Care case management services while they're residing in that option. So we hope to explain as best as we can what is required as far as assessments and paperwork and the process for Choices for Care for individuals in the AFC option when there is no case management. So as you know, adult family care is our only Choices for Care 24/7 home and community-based option. It's available to Choices for Care participants who are in the highest and high needs groups, so who meet our nursing home level of care for clinical eligibility. And this option is where an individual resides with a home provider who is unrelated to them. The home provider can have no more than 2 unrelated individuals in the home at one time because it is an unlicensed option. So individuals who were already enrolled in Choices for Care and living in another home-based option, such as using flexible choices, a budget, or using traditional home-based services, and then choose to move to an adult family care home, these individuals currently would have case management. And those case managers would be allowed to work with the individual through the transition from a traditional home-based option or flexible choices home-based option to adult family care. So we do want to allow case management for continuity of care when it makes sense. Just as we were talking about, if an individual currently is enrolled in Choices for Care and is receiving services in the community and has a case manager, we want that case manager to be able to continue to work with the individual through the transition for that continuity of care. So as an example, it could be that we have an individual who is residing at their own home, receiving traditional home-based services, and then gets admitted to a nursing facility for a lengthy stay, and then coming back out of the nursing home, chooses to go back to the community, however decides that they're living in their own home may not be the best option for them now, so they would then choose the adult family care home option. And if this is the case, they would have had a case manager prior to their nursing facility stay, and if they were still involved with that case manager, the case manager could certainly work with the individual from the transition from the nursing facility back to the back out into the community to the adult family care home, and the case manager could work with the individual up until the individual actually moves in with the home provider. So there's going to be some new responsibilities for the AFC coordinator at the authorized agency. The authorized agencies are still responsible for all of the things that we outlined initially when this option was rolled out. But now a new responsibility will be to complete the adult family care ILA assessment, the AFC tier scoring worksheet, and the AFC service plan, and any other documentation. So typically the case managers had completed the AFC ILA assessment. So since this is new, it's just important for you to know that the AFC ILA assessment as you already know, is what we use to assess an individual's physical functional abilities and to assess what their current needs are. But it also is used and puts weight and scores the tier for the individual, which then determines the rate of the tier payment. So the tier payment covers the 24-hour long-term services and supports, including personal care, any respite or companion care. The tier payment does not include payment for adult day or acute care services, which would be anything covered by insurance, or room and board. The individual is responsible for paying room and board from their own income. So the tier, again, is developed by using the AFC ILA and the tier score worksheet. After the participant has signed an agreement or enrollment with an authorized agency and the tier has been determined, the authorized agency can bill up to $35 a day for pre-transition services leading up to the person's move-in date to the AFC home. After the person moves into the AFC home, then the authorized agency can bill the full tier amount and maintains 5% of the tier payment for administrative fees and service coordination. And then we just outlined that the individual pays their own room and board, but we do have a Dale room and board standard. And as of 1/1/15, the maximum room and board amount is $707.69 per month for the individual. However, the individual must retain at least $124 a month personal spending. So this next slide outlines generally the choices for care, adult family care process, and we know this is ever evolving. So currently, an individual would be assessed clinically by the long-term care clinical coordinator. They would also need to meet the financial criteria for choices for care to be eligible. They would choose the adult family care home option. After choosing the AFC option, they would also have to choose an authorized agency to work with. So historically, we were able to have case managers get involved and make referrals on behalf of the individual to the authorized agencies and then complete the follow-up. However, now that we no longer we may no longer have case managers working with all individuals transitioning to the AFC option, you may find that referrals are coming from other sources, for example, directly from the nursing facility. So if an individual had a nursing home stay and applied for choices for care while at the nursing facility, so therefore they were never involved with a case manager through choices for care, then the nursing home social worker may likely be the one making referrals to the authorized agency on behalf of the individual. Or it could be the individual themselves. Or it could be an individual who is hospitalized and applies for choices for care. So you may start seeing referrals coming from other places. We do currently have a referral form in draft that we're hoping to discuss and make available both to our choices for care case managers as well as other choices for care providers for that purpose. So once the individual chooses the authorized agency, the authorized agency would complete the AFC, ILA, and tier score if they do not have a case manager who does this, who would do this. Because you're going to want to know what the tier score is as you move forward in deciding whether or not you would be able to work with this individual. So the authorized agency would then have to send the AFC, ILA, and tier score to the long-term care clinical coordinator nurse, because the nurse would need to just confirm the tier. They do a utilization review process that basically is a process whereby the nurse determines that the individual's needs are met. And then they would confirm the tier with the authorized agency. So there's a couple of different ways for agencies who are not using our SAMS database. There is a paper AFC ILA and tier score sheet so that you could either fax it or secure email it to the long-term care clinical coordinator nurse in your area. So once the tier is confirmed, then if the authorized agency decides that this is an individual that they would be able to do the home provider matching process work for, then the authorized agency would sign an enrollment form with the individual, basically saying that the individual agrees to work with that one authorized agency. And again, this is another form that we have in draft currently. And once you sign that form with the individual, then you can start to bill for the pre-transition work. Now, you want to make sure that if this is a new Choices for Care applicant, then they may have had the clinical eligibility determination completed, however, may not have been approved financially yet for long-term care Medicaid. So you may want to check on that status before you dive into the pre-transition work, or typically when an individual is approved for long-term care Medicaid, the approval goes back to the date of application. So you would still be able to bill for the services, but it might be delayed. If it's an individual who's already enrolled in Choices for Care, then you can just go ahead and start billing for the pre-transition work once you have signed that enrollment form with the individual. And as it stands right now, and this may be subject to change, the policy states that you can bill up to 60 days from the date that you sign the enrollment form with the authorized agency, or with the individual who's choosing the AFC option. So then the authorized agency starts the pre-transition and matching process. Once the home provider match is found, then the authorized agency will have to complete the AFC service plan and send that to the LTCCC nurse to sign and authorize, and they'll send that back to the authorized agency. So once the individual moves in with the home provider, then the authorized agency can bill the full tier amount as soon as they've received the signed and authorized copy of the AFC service plan. And just a note, there may also be a Choices for Care Money Follows the Person transition coordinator working with an individual who's choosing to move to the AFC option. And this would be typically an individual who is transitioning from either a nursing facility or a hospital. And the individual may have transition funds available up to $2,500 to use when transitioning back out into the community. And the transition coordinator is responsible for assisting with the transition as well. So I'm going to show you what the AFC ILA looks like, and there's also the web link to it. So the first page, well, in total it's 20 some odd pages long. The first page is demographic information. It's broken into different sections, as you can see right here. And this is the paper version, which most of you will likely use until we're able to get you using SAMS. So just important components, it asks for assessor information, so that's going to be who's completing the ILA, at least the majority of the ILA. There is a section that a registered nurse or a licensed practical nurse has to complete. That's the health section of the ILA. And it's pages 15 to 18. And it asks, we'll get to that, and I'll show you why a nurse has to fill that out. Here's emergency contact information. That's always important. You don't have to put directions to client's home because we have the address, so you can skip that. We do want to know the kind of assessment that it is. Is it an initial assessment? Is it a reassessment? Or is it an assessment, an update because of a significant change in the individual's functional status? So it'll be an initial assessment when it's the very first one that's completed for this individual. And then individuals enrolled in Choices for Care are required to have a reassessment on an annual basis, both for clinical and financial eligibility, or if there's a significant change, then the ILA can also be updated. So the next section asks about the legal representative. So if there's a power of attorney or a guardian, it also asks about advance directives for the individual. Then there's more demographic information and some health-related questions around hospitalizations, nursing home stays, falls. Do they use a mobility device? So you can feel free to make notes in any of these sections. The more information and detail we have, the better. There's a nutrition checklist, and so you can score that just to see if somebody's at risk nutritionally, to come up with a plan around that. Or do they need a referral to a nutritionist through their primary care provider's office? We want to know about prescription medications. Height and weight is important. Weight is important just because if there's ever a significant weight loss or weight gain, that's one way to keep track of their weight on an annual ongoing basis. Are they enrolled in other programs? So you can check off what other programs they may be also enrolled in public assistance programs. There's a whole section around, the assessment for income and poverty. I'm not sure how you would use this, with the exception of wanting to know the client's income for room and board and for personal spending. Because DCF Economic Services has all this information from when they've applied, and then asks for it also on an annual basis on the 202 LTC Medicaid application that has to be sent in on review. So if you don't have all of the financial information, that is okay. Here, as you can see, it goes into burial account and all kinds of other detailed information that was typically used by case managers. But you may want to make note of whether or not they have a Medicare health insurance plan, or other insurances and resources. The next section is around self-neglect and exploitation, or abuse, neglect, and exploitation. So this is important. We're going to want to know if the individual is putting him or herself or others at risk of harm. Are they safe? Can they make decisions? Is there any evidence of suspected abuse, neglect, or exploitation? And of course, if there was, we would expect that an APS referral was made. Okay. The next section is around supportive assistance. So who's the primary unpaid person who usually helps the individual? I don't know if there will be somebody or not. Maybe they do have a family member who's able to provide some respite when they're living in the adult family care home option. So anything you can note about that would be helpful. Asks about the living environment. Are there any hazards, structural barriers, safety issues? And there's a brief emotional, behavioral, and cognitive well-being screening, which asks about feeling down, life satisfaction, or is somebody at risk of harming themselves because they are depressed, and if so, then have they been referred to an elder care clinician or other mental health supports? What is their ability, their cognitive status, and their ability to make decisions? Are they having any behaviors? And if so, is it daily, redirectable, or not? And here's where we get onto the health assessment, which is completed by the RN or LPN, and asks about medical diagnoses and other conditions. We want to know if they've had any recent infections and other problems. Are they getting therapies? Basically, this just requires the nurse to do an assessment and make note of anything in particular that may be going on with this individual or something that has changed in their health. We ask about pain, incontinence, skin integrity. And then there's a spot for the RN or LPN to sign off after they've done the health section of the ILA. Next is all the functional assessment. And this just goes through all of the activities of daily living, and then later we'll go into more detail around how you know when somebody is independent or just requires supervision or is a limited assist or extensive assistance or total assistance. So we'll provide some guidance around that. So it's both for activities of daily living like personal care, and then IADLs, which we call instrumental activities of daily living, which is like being able to use the phone, medication management, meal preparation, housekeeping, all of those kinds of things. And of course we know that when somebody's living in an AFC home, it's for a reason. They likely need a lot of support around all of this. So that's a quick breeze through the 26 pages of the ILA. It's pretty self-explanatory. However, if you do ever have any questions, you can always talk to your local long-term care clinical coordinator nurse who would be more than willing to help you out. Again, make as many notes, handwritten notes as you can, because we know check boxes aren't always clear, and that's not really a true assessment, just checking a box. Okay, so that's a quick look at the ILA. Again, here is the web address as to where you can find it on our website. So what does a good AFC ILA assessment provide? Person-centered care planning is the intent, although we know this tool doesn't quite capture or have a space really to identify what the individual's goals, wants, needs, desires, strengths are. But like I said, you can always add handwritten notes anywhere in the ILA. So we wanted to really paint a picture of the individual's strengths, needs, and preferences, to be able to identify from the assessment what the individual's care needs are. It will help you to formulate the care plan or service plan. And again, it gives us common knowledge to work on common and shared goals together for the individual. So an accurate assessment requires information from multiple sources. So if there are service providers that are working with this individual on a regular basis in addition to the home provider, you can certainly gather information from them if the individual gives you permission to do that. Can certainly validate information collected from the individual when it's gathered from family or other people from their support team. We do want to stress the importance of observing the individual to most accurately assess their physical functional abilities, so we'll talk some more about that. And then again, just to reiterate that a registered nurse or LPN must fill out the health sections of the ILA, which are pages 15 to 18. So if your authorized agency has a nurse, it could be that nurse who completes it. It could be a local home health agency nurse, so I'd encourage you to reach out to the local home health agency in your area to ask them about completing the health sections of the ILA for Choices for Care participants. If the individual does attend adult day, the adult day nurse could do it, or it's a little more challenging, but you could approach the nurse at the primary care provider's office. Just usually we find there's delays in getting the information back because they're busy. So as you know, anytime you're doing an assessment with an individual, it does provide the opportunity to develop a rapport and a trusting working relationship with the individual and the others who are caring for the individual. And certainly, to welcome family or others who are part of the support team if the individual is choosing and desires them to be present as well. So the ILA should be completed initially. It could be completed by the case manager if the individual has a case manager and is transitioning from like a traditional home-based option or is enrolled in the flexible choices option and has a case manager and they're transitioning to AFC. If they do not have a case manager, then it should be completed initially by the AFC coordinator. And then it must also be completed annually at a reassessment by the AFC coordinator, or if there is a significant change in the individual's condition, you'd want to complete or update the ILA with recent information. So a significant change, we define that as a decline or an improvement in the individual's health status. And it has to be a significant decline or a significant improvement in the individual's health status. A new assessment is not required if the individual's condition is expected to return to baseline within a short period of time. So if the individual does have a significant decline or improvement, if it's appearing as though it's not going to last, that it would just be that way for a short period of time, then you do not have to do an updated assessment. Guidelines for a significant change: basically, if there's a decline in 2 or more activities of daily living where the individual's function is newly coded as requiring extensive or total assistance. Extensive being they now require physical hands-on weight-bearing assistance, and total assistance being that they no longer are able to participate in that activity. Or if there's improvement in 2 or more activities of daily living where the individual's function is newly coded as independent supervision or limited, so that means they no longer require extensive or total assistance. Their function has improved, so now they just need some limited assistance, which would be some, contact guard assist. You're not bearing the weight of that individual. Or supervision, which is just supervision. You can stand back and allow them to do the activity, but somebody's present just for safety reasons. Or they're completely independent with their function. If there's a new diagnosis, which is likely to affect the individual's well-being, we'd consider that a significant change. If they have developed a pressure ulcer or some sort of wound, any unplanned weight loss, 5% in 30 days or 10% in 180 days, or if they have challenging behaviors and then there is an improvement in their behavior or mood or functional status to the extent that their current assessment no longer reflects the individual's current function, then you would want to update it. if there's a deterioration in behavior or mood to the point where daily challenges do arise. There's a prolonged state of mental confusion or decline in mental alertness. Those are indications of a significant change. Then you only send the revised AFC ILA assessment to the long-term care clinical coordinator nurse when the functional change creates a change in the tier on the service plan that's being requested. So the AFC ILA assessment categories, we walked through the ILA a little bit. There is a category around cognition, and as you were all aware, cognition is how a person thinks, their judgment, remembers, and is able to make decisions about their daily lives. Many things can impact their cognition, including their environment, medication, the time of day, if they have an acute infection going on. And so conversing with the individual and having them show you around their environment can give you clues to how they think and understand and whether they are having any difficulties with their memory. Memory recall is what was learned or known, so for both the short and long-term memory. So we do assess this. And I'm sure you can think of a lot of questions or things to elicit responses to determine if somebody is having any difficulty with their short-term memory. Things such as, what did you have for breakfast? And then can you validate what they had for breakfast? The long-term memory, certainly, when is your birthday? How old are you? How many children do you have? Do they remember their names? And then we code for cognitive skills for decision making. So in the ILA, we record the individual's performance in making everyday decisions about tasks or activities of daily living. So independent, are they able to make their own decisions? Modified independence would be, are they able to organize a daily routine and make reasonable decisions in familiar situations, but maybe they experience a little difficulty making decisions when they're faced with new tasks or situations. Moderately impaired would be when individuals' decisions are poor. So they would not eat or ever attempt to wash or get dressed if they didn't have somebody there providing constant reminders and cues and supervision and helping them plan and organize their daily routines. And then we would say somebody is severely impaired when they're never or rarely ever able to make any decisions despite being provided opportunities and appropriate cues. For physical functioning, we look at range of motion, and this is really helpful when you're assessing for an individual's physical functional abilities. So these are just some tips, different body areas as what you can have individuals do to get a sense of what their range of motion might be like in their neck, their arms, hands, legs, and feet. Then we also have codes for physical functional abilities as well, which are under each activity of daily living in the ILA. So a 0 is independent, which means they're independent. They don't need any help or just need limited oversight. A 1 is supervision, so it's eyes on only. You're not touching the individual. They need cueing and perhaps they need cueing and encouragement and direction 3 or more times over the last 7 days is how it's spelled out in the ILA. Limited assistance is a 2, and that would be you're touching somebody to guide them or help them maneuver their extremities or limbs, but you're not supporting the weight of their extremities. Extensive assistance is when there is a need to lift or pick up the extremity. You're actually supporting that individual's weight. And then they may need full assistance occasionally in addition to that extensive assistance. And then total assistance is when they need full caregiver assistance each time the individual is not able to physically participate in any of the activity at all. And sometimes you have individuals who do have dementia where, physically they're still capable of moving. However, they may be late in their disease process where they aren't able to follow any cues. So the caregiver would have to do, or would have to provide full or total assistance to assist that individual in managing their ADLs. So the best tips we can give for physical functional assessment are that you observe. You want to score the highest level of support provided to the individual by the home provider in the last 7 days, even if that level of support only occurred once. And just a note, there is a difference in how bathing is coded. Bathing does not include washing the back or hair because everybody likely needs help with that, and there's assistive devices that can assist with that. And so when you're looking at bathing, just the coding definitions are slightly different. So it's coded as independent supervision, which again is just a supervision, but then limited assistance is physical help that's limited to the transfer in and out of the bath or shower tub, whatever it might be only. And then extensive assistance is physical help in part of the bathing activity. Or then total dependence is full assistance every time. So we do encourage you to make notes describing the individual's functional ability. And then if you're using the ILA in SAMS, you'd want to make sure that you date and initial the notes. But if you're doing the ILA on paper, you're going to be signing off on the whole ILA. But you can certainly still initial any notes that you make next to the ADL. Again, for any questions, always feel free to consult with your local long-term care clinical coordinator nurse. And their contact information is at the end, the last slide of this training. So once the ILA is complete, now what? The next step would be to complete the AFC tier score sheet, and I will pull this up and show you what that looks like. So here's the paper version of the ILA tier score sheet. If you are using SAMS, the score sheet will automatically populate based on your responses in the electronic AFC ILA assessment, so it's much more efficient. So basically, what you want to do is look at the different steps of the score sheet. So step 1 tells you to look at the elimination status, which is section 5D of the health assessment on page 17. So if you go to page 17 of the AFC ILA, then you'll be able to find the frequency of bladder incontinence and how frequently the nurse had reported that this is occurring for the individual. And based on what that report is, then you can assign the points to it. Step 2 is section 6A of the functional assessment of the AFC ILA. So that's looking at all the activities of daily living. So again, it points you in the direction of where you can find all of the information you need, pages 18 to 20. And again, under each ADL, you want to look at how the individual was scored and then assign the points accordingly. So it goes through dressing, bathing, personal hygiene, bed mobility, toilet use, adaptive devices, their ability to transfer, mobility, and eating. And then it also looks, step 3 looks at section 6B, instrumental activities of daily living, and that's on page 21, where you'll find information about the assistance needed with meal preparation and medication management. So then it tells you to add all the points from steps 1, 2, and 3 together and put it in this box. Then you want to add 19 points to the total from steps 1, 2, and 3. So you'll add 19 points. So then you'll add your points from step 1, 2, and 3 plus the 19 points equals your AFC tier points. So once you have your total AFC tier points, that's your score. So you'll look down the score. Say I had 110 points. So I find that's between 107 and 119, which means I'm a tier 7, and the corresponding rate is $116. So that would be my tier and rate. So once you've found your tier and your rate, you'd want to include that. You'd want to then send the AFC ILA in the tier score sheet to the long-term care clinical coordinator nurse. Again, they would then do utilization review and just confirm the tier with you, so then you could continue to move through the process with the individual in the pre-transition work and home provider matching process. Once the individual, or prior to the individual moving into the home, once you know the move-in date and you have the tier confirmed, then you would want to complete the AFC service plan. I'm going to show you what that looks like. And I believe this is still the old one that has the case management on it, but we will be linking a new one to this spot on our website. So this is what the AFC service plan authorization looks like. You've probably seen this before. We have added a space for an ICD-10 code, so I just want to briefly mention here, as of October 1st, 2015, anyone who uses ICD-9 codes has to transition to using ICD-10 codes. So part of our plan is to start gathering both codes right now and get those into our system. So we're requesting that you put both an ICD-9 and ICD-10 diagnosis code on the service plan for us. So as you can see, this is our previous service plan. So it still has the case management on it. So this case management line will be going away. And we should have this new service plan updated and posted on our website at the same link that I used in this presentation for you today. So you'll just want to put in the agency, the authorized agency name, the tier number and the tier rate, and then calculate the rate on a monthly basis. And then you'll also want to note if the individual is attending adult day, where the individual is going, the number of hours per week, and then to calculate that cost out to give a monthly total. If you know that the individual is also receiving some skilled services through the home health agency, through a referral from their primary care provider, that would be really helpful to know. And or if they're also enrolled in CRT or another program, or maybe they have hospice services. So once we know the date the individual will move into the AFC home, that would be the date we would use as a start date for the service authorization. That would then allow the authorized agency to start billing for the full amount of the tier as of that start date. And this will be signed, the Dale authorized signature is the LTCCC nurse's signature. On the back of the service plan, you will want to have the individual or the individual's legal representative sign off on the service plan along with the authorized agency AFC coordinator. And then again, this case manager line will be going away because that is no longer needed. on the service plan. And also included is just a guide to the tiers and the rates. And it also includes, the rate when an individual is in a hospital. Authorized agencies can bill up to 94% of the daily rate up to 30 days that the individual is hospitalized. So that gives you a guide. So just again, a little note about the ICD-9 and ICD-10 diagnosis codes, to have those on there. You want to submit the complete packet to the LTCCC nurse. So that packet includes the AFC, if you haven't already, the AFC ILA and score sheet, and then the AFC service plan. And we can continue to have conversation around the process and how this works most efficiently. So we do understand that the ILA does not put weight or create a score for certain things that are assessed for, such as when an individual has cognitive or behavioral challenges that require highly intensive supervision, such as 2-to-1 or 1-to-1, or if the individual has cognitive challenges that require intensive supervision, which is not the 1-to-1, but just constant redirection to maintain safety for themselves and for others. Or if they have a cognitive and behavioral challenge that prohibits them from being able to attend adult day as an option for respite for the home provider. So these are 3 of the main reasons we would certainly entertain allowing a variance to the tier for someone. And we have a draft variance form created, so once we have that finalized, we will get that out to all the authorized agencies to use. So the draft form is going to be Choices for Care Form 708. You can use to request a variance. Again, it's in draft right now, so we're not going to post it on our website until it's finalized. But it is the authorized agency's responsibility for requesting the variance to the tier. And currently, if you'd like a copy of the draft form, you can contact Sarah Lane or Paula Brown at those email addresses listed. For individuals enrolled in Choices for Care who are also enrolled in Money Follows the Person, may use up to $2,500 to transition from a nursing facility or a hospital back out into the community if they've been deemed eligible by Money Follows the Person. So I'm going to show you the transition form. So this is the Money Follows the Person Transition Fund Request Form. As you can see, it was typically only used by our Choices for Care case management agencies. However, now that individuals will be enrolled in the adult family care home option without case management, it would be the responsibility of the service coordinator at the authorized agency to fill out this form. So this form requests the individual's information and then the items that will be purchased using the Money Follows the Person transition funds. This form gets filled out by the service coordinator and then will be sent to the local transition coordinator for Money Follows the Person. All the items that are requested need to be pre-approved by the transition coordinator. Once the transition coordinator approves the items, then a prior authorization will be put into the MMIS Medicaid system. So once the agency receives the prior authorization notice of decision for the amount of the transition funds, the agency can then go ahead and purchase all of the items that were requested on the transition fund form, and then be able to directly submit claims to HP for the items that were purchased. Here is an outline of the MFP Transition Funds request form process, as well as transition fund request form policies. So the important things to note is that a prior authorization and pre-approval does need to be done before transition funds can be utilized. The individual also will have to have moved out of the nursing facility or hospital to the adult family care home before these items can be purchased. Once the agency purchases the items, they can then go ahead and bill Medicaid for reimbursement for the items that were purchased. And there's additional guidelines around dates of service and billing, and so we will make sure that you have access to that information for the folks in your billing department as well. So if an individual requires additional assistance, since they will no longer have case management in the adult family care home option, things that the case manager may have helped with in the past was help filling out Medicaid applications. So the family of the individual or whoever they have listed as their alternate reporter for notices of decision from DCF Economic Services can certainly help with the long-term care Medicaid application renewal process on an annual basis, or certainly the AFC coordinator could help. If family or the AFC service coordinator is not able to help, then they could certainly contact the senior helpline. If an individual needs help learning what additional community supports or options are, if they're age 60 or over, they can contact the senior helpline. If an individual is under the age of 60, then they can contact the Vermont Center for Independent Living. If an individual requires help with benefit appeals or legal issues, they can contact Vermont Legal Aid. And again, if they have any complaints that they need help to resolve, they can contact the Long-Term Care Ombudsman program, which is through Vermont Legal Aid. So all of those resources are listed on this slide. The other thing that we will be sure to make available to you is a list of our long-term care team, which includes all of our long-term care clinical coordinator nurses, the transition coordinators, and our folks at DCF Economic Services who process the long-term care Medicaid applications. We do have a complete list of our team all on one page that we will make available to you, so that way you have everybody's contact information should you need it. So we will plan to do follow-up phone calls from this training to answer what questions you might have, or if we've overlooked something or need to clarify something from this training. So please be sure to have all of your questions ready, and we will let you know when that phone call is scheduled.